Do you have any last minute advice for the exam tomorrow?
Yeah, we'll get to that eventually. We're gonna have a conversation first. So in 2017, there was a case in Nashville, Tennessee with a nurse who administered the wrong medication. Do you remember this at all?
No.
Okay, so this medication that she gave, she was supposed to give Versed, right? What type of medicine is Versed? Sedative, right? Benzodiazepine type medication that we give. She was supposed to give it for a client who was having anxiety before they went into the CAT scan. Do you remember what she did give instead? Vecuronium, which is what? Paralytic. Okay, so when we talk about the different types of medications and we talk about why we need to know and why it's so important, and I know that a lot of times we think nursing instructors make us memorize medicines and it's no big deal because I'm just going to use lexicon and I'll figure out what it is. Okay, so this is a quick video, but I want to have a really good discussion about why this is important. So this is an interview with her that after the fact, okay?
A sense of peace here, a sense of home, a sense that God's country is not just a Southern expression, it's something much more.
Every day is a gift. Every day that I get up to see my home is a gift.
Here in her serene corner of rural Tennessee, Redonda Vaught lives her small slice of the simple life, an almost unimaginable reality from the maelstrom that the 38-year-old former nurse has lived through.
Do you feel like you were a scapegoat? Like the whole world feels like I was a scapegoat. There's a fine line between blame and responsibility, but nothing is done in a vacuum.
The trial begins for a former nurse at Vanderbilt Medical Center accused of administering a fatal dose of the wrong medication.
For the past 5 years, Redonda Vaught has faced the fight of her life. A former intensive care unit nurse who in 2017 accidentally gave the wrong drug to a patient, Charlene Murphy, causing her to lose her life. A tragic mistake, but what followed was a whirlwind that surprised many. Criminal charges and a conviction for an accident.
We, the jury, find the defendant Redonda Leanne Vaught guilty of criminally negligent homicide.
Tonight, the nurse at the center of it all.
And you play this over and over and over again. Every day. So many times, over and over and over.
And
We went from healthcare heroes to sacrificial lamb.
the nationwide fight for change from the frontline workers, fearing they could be next.
Almost every nurse has had a medication error of some sort. That could be any one of us.
Did you like being a nurse? Yeah, you have this purpose to take care of them. You just want to do the very best you can.
It can take a lifetime for someone to find their purpose. By 2017, Redonda Vaught knew that she had found hers in the neurological intensive care unit at Vanderbilt Medical Center in Nashville.
It's Christmas time, 2017. Elderly woman named Charlene Murphy is admitted into the hospital for brain injury. She's treated, soon ready to be released, but needs a final scan before she can be sent home, which requires her to have a sedative because she was nervous about the scan. You're the nurse that's now called in to help. When did you realize something was wrong?
It wasn't until she had been brought back to our unit as an intensive care patient, and a code had been called in the PET scan area where she was.
Redonda was supposed to give Charlene a sedative, Versed. Instead, she accidentally administered a powerful paralyzing drug, vecuronium, a catastrophic mistake, which caused Charlene severe brain damage.
Her primary nurse had approached me and it showed me the vial of medication and asked is this what you give her? And it wasn't until that time that I realized that it was the wrong medication that I had given her.
At 75, Charlene would die from that fatal dose.
When you saw the vial and you read what was on the vial, what goes through your head?
Your heart goes through the floor. You just, you can't even imagine.
Vanderbilt fired Redonda, but what came next shook her to her core. After multiple investigations, her nursing license revoked, and the National District Attorney charged Redonda with reckless homicide and abuse of an impaired adult in 2019.
Those words,
Reckless homicide. Abuse.
Prosecution basing its case on what they say were 18 egregious actions and inactions that killed Charlene Murphy. Among them, they argued, was overriding the system used to obtain drugs and ignoring a warning directly on the vial cap.
We had to use the override function to obtain medications.
this was like a normal part of your routine, having to hit override.
No, you couldn't obtain an IV fluid without hitting the override button.
Vaughn admitted she was distracted that day because she was escorting a trainee.
Anytime you have an additional responsibility, that responsibility can be distracting. I allowed myself to split my focus.
But Vaughn's attorneys argued that her fatal mistake was made possible by systemic errors involving the hospital's pharmacy, which allowed nurses to routinely override safeguards. A 56-page federal investigative report following Murphy's death also outlined deficiencies found at the hospital.
So many things had to line up incorrectly for this error to have happened. And my actions were not alone in that.
We're not talking about an intentional act. We're not talking about a nurse trying to kill a patient. A medical error will lead to a criminal charge, and in particular, a charge of homicide. That's very, very rare. I can't think of another recent instance where it has occurred.
Neither the
So if you remember this, it was a huge deal because not only did she get charged, but it sort of incited this whole thing on why are nurses the ones who are the last line of defense? Why are we the ones who are responsible for like a whole system of errors? So pharmacy was a problem, the way it was accessed, there were just so many things. So I just wanted to make sure that when we are teaching you medications, we always hear that, you know, you guys, we focus a lot on them and things. But that's why. So Versed comes in liquid and vecuronium comes in powder, and you actually have to reconstitute it. So one of the questions that they had was, how distracted was she allowed to be that she not only picked the wrong pocket and grabbed the wrong med and overrode it as she went, but she also had to think, oh, I have to reconstitute this med, which I really wouldn't have to do because Versed, we give IV push, it's already liquid. So what are your thoughts on the responsibility that you have in the system with the patient? Anna, you had not heard of this before, right? Okay, so what are your thoughts hearing it first time?
There's a part of me that feels like it's kind of insane that she got that level of like a punishment. Then there's also a part of me that can't understand it, because when you're thinking about like, yeah, she had to reconstitute it and everything, there should have been red flags going off. But then she also said like, oh, like I was distracted, I was training somebody, and so like it genuinely could have happened. Like I could see myself, hopefully never not in that kind of situation, but just like being distracted while you're like trying to multitask, it happens to everybody and anybody. And yes, unfortunately, this one ended up with her accidentally causing somebody to lose their life, but it wasn't malintent. She wasn't doing it maliciously. She wasn't planning it out. She wasn't like, oh, well, this patient sucks, I'm gonna go kill him. Like she wasn't doing that. She was trying her best with what she could do. And she was there trying to take care of her, and so it makes me sad for her, that was the kind of punishment that she got. Because obviously she had to be a good nurse in the first place to be treating somebody else. So that means that we, like, healthcare systems, that hospital lost a good ICU nurse because she accidentally made a mistake.
How was she even able to like get that med without the order? Did she not look at the order before she was gonna go grab that med? So I don't know their system, but I have worked places where instead of the Pyxis where like one drawer pops up, the whole drawer opens up. And so tells you need to pick pocket, so well, I won't say 'cause it's on film, but there is a facility that I worked at here locally that when you go in, it doesn't necessarily populate the orders and you pick what you want. You have to go in and find them. So like my whole drawer will slide out and it says pocket 3, whatever. And so I count pockets, they're all open and I just pick what I want. And then it's on me that I pick that medication and I'm saying, yes, I picked the right one and I close the door and go on my way. So it's not always like a locked.
So, okay, follow-up question. Well, like, we've been taught, like, the number one thing a healthcare worker mistake is like med mistakes. Why is it there more technically, like, of trials like this, situations like this? Because like med errors do happen and whatever, yes, hers ended up with that one patient losing their life. But if that really is the standard that they're going to place nurses under, then why isn't there more kind of like getting this like punishment of like losing their license, going to jail, doing all that stuff? Because it just doesn't seem fair that like she's the only one, honestly, that was like singled out like that.
Yeah. Have you guys heard the Swiss cheese theory?
No.
So if you would line up slices of Swiss cheese, right? And so like I picked like 5 slices and I put them all together, there might be one hole that lines up. But if you put other slices of cheese, like all the holes are gonna be in different places, right? And so that is what they use when they talk about safeguards in place. So if something passes the first level and it makes it through, then we know that's a person error, right? Like it might be an isolated thing. And then if it happens again, it happens again. So if you get to the point where it has passed through multiple levels of safeguards or multiple processes and procedures and it still happens, that's not a one person thing, right? It's like a systemic error. So we encourage, I've made med errors, 100%. I have made med errors, right? It has not resulted in the death of a patient. It has not even resulted in any harm to a patient. Everybody does that. But if you are not willing to say, oh crap, I screwed up, that was a near miss, right? Like that was even, I almost gave the wrong thing or I did whatever. If we don't report that because we're afraid to admit that we almost made a mistake, then we can't trace where that process messed up. Does that make sense? So we have to be able to trace that data by saying like, oops, I brought this med into the patient's room and I almost gave it, but I stopped and scanned and realized, oops, this is the wrong patient I'm on or the wrong bed or whatever it is.
Did she give the medication without scanning it?
Don't know.
And that's my problem, is that the hospital, she made a bad mistake.
Yeah, right,
I mean,
absolutely.
horrible. I mean, especially if you have to reconstitute, like you should know better than that. And you should definitely get punished, you know, like maybe with the board of nursing and stuff. But the hospital system should safeguard.
Just sounds like there's shit, like, you know,
Yeah.
you scan a med and.
Yeah.
They'll pop up and say, hey, you don't have the right one.
Right, but have you ever seen a nurse ignore a pop-up?
Yes.
We have pop-up blindness. We get them all the time. How many times do you get that sepsis alert? You're like, yes, we know. I already notified somebody, right? And we keep going.
They're still saying that like, all the nurses have to override like everything on their system. So yeah, that's a total hospital system.
Yeah.
I'm just saying
You have to-
hospital should have took some
If you have to
accountability.
override a
Right.
IV,
Right.
that's.
And
That's.
my thought, doctors have malpractice insurance, so they don't get taken out personally. There was their pharmacist wasn't mentioned and the, computer technician wasn't mentioned and the person who stopped the machine. Yeah.
So my question is, say that like she did scan it, she went through all of the motions of doing it. But if that was like a PRN medication that was prescribed, like on her MAR, she scanned it, it would still get approved through, would it not?
You would think.
So there's no, this, if she, again, like, because she was distracted, whatever, doing a million things, which we have to do as nurses, we have to multitask, we have to be able to do that. If she did scan it and she went through all of that, there's no way for her to actually really tell in the end because it went through on the system.
Well, and there's more questions than we have answers, but I have been in a situation where I've sent a patient down for a scan and I get a call from the CT person or the MRI person, whatever, like they're freaking out. Can you come give them something? And so I call or I get a verbal order or I check the order or whatever it is, and I put the medicine in my pocket and I go down and I administer at the bedside because they're in an emergency, like they're combative, they're flailing around, whatever, they can't get it done, their patient's not safe. I give the medicine and I come back up and I document it. That's huge. I should not do that at all, right? Obviously, I'm not doing real-time charting. Have I done it in the past? Yes. Do I think twice about it now? 100%. Right? Because there's things that we do where we think like, oh, this makes sense to override whatever process because patient safety, right? Or like, we need an order right now, or I'll get an order later, whatever the case may be. Right? It's not right. I don't know that, but I had a friend who inadvertently, this was again before computer charting, because I'm old, but it was an order for epi for somebody with an allergic reaction. And for whatever reason, the nurse read epi and he thought amp of epi, not vial of epi. And when you typed in epi in our computer, in our Pixis system, or, Omnicell or whatever the system was at the time, and you typed in epi, you had to pick what it was you wanted. It didn't automatically populate. So he typed in epi, it comes in the vial, it comes in the syringe. He picked the syringe, got it, went in, pushed it, and then went, oh crap, when the patient started having an MI because we gave him epi and he didn't need it. So, he didn't lose his license. The patient did, we had a whole lot of legal stuff. Still working as a nurse.
Do you think that sometimes nurses, depending on who else is on staff, won't go and like double check things or ask for help or do stuff like that because they don't want to be seen as a dumb nurse, as
Yes.
a bad nurse?
Yes.
I hate that mindset and I hate that kind of like environment to be around or to be in because you feel like you don't have any of that support. And who knows, maybe she could have been with like a bad staff and she was already overwhelmed because she thinks that they're like reading into everything that she's doing. And they just,
And so if you watch the rest of this video, and I can post a link if you want, it ends up being the nursing community as a whole rallies around her. And at that time, when this news broke, before the investigation, before the chart, before all of the things that we now know, looking back, there were rallies. It was hashtag I am Redonda on everybody's social media because every nurse was saying that could have been us at any given time. We are overstaffed. We are underprepared. We don't have the support we need. This could be anybody. And she's the one who's, the fall guy for it. So it's just a really interesting conversation to have, both now preparing for your practice when you have your license and things that now I have a license, things that I will do differently based on this, knowing that she did end up with, legal issues with it. It's a really good discussion. Yeah.
Do you know what the outcome of that was?
She ended up being sentenced, but then it was like, so much of it was time served or parole or whatever it was. So she ended up at home. But yeah, she's no longer allowed to practice at all anymore. That's for sure. 100%. And if we talk about a paralytic, she was wide awake when she was in that scanner. Like that patient was wide awake, unable to breathe, unable to move, unable to signal for help at all. And she had a terrible death.
is that how she died? Is because she couldn't breathe?
Yeah, she was
They
paralyzed.
said something about like her brain, something that affected her.
Right, because she couldn't breathe, so she had hypoxic brain injury.
Oh my gosh.
Yeah.
That's terrifying.
Yes, which is why I always preach to you, you have to sedate your patient before you paralyze them, because I don't want to know that I can't move or breathe. Yes.
Did you not know that she was going, like, how did they even get her into the machine?
So, and again, I've been there where you put your patient on they think that, yeah, we're explaining to you, right, education, this is what the procedure is gonna be. Yeah, I'll do it. You get in there, you get them on the thing and they go to slide them through the donut. They're like, whoa, I can't do this. I can't do this. And so there could have been a PRN order in, or they could have called and gotten an order. So she very likely would have given it to her as she was already on the cot or on the bed to have the procedure. And I've done that where I have medicated them and then I stand in the CT suite and I watch them slide in and I watch them slide out. So you don't have anybody in there unless they're on a monitor, which how many of our patients are actually on monitors all the time? Not that many. So she was gonna be discharged. She needed one more scan. She probably medicated her, let her in. She said, are you good to the CT tech? They said, yep, we're fine. She went back to the floor. And then when they pulled her out of the scanner, they realized it. It's not like you can see them, you know what I mean? Like you can't be in the room because it's radiation. It's a lot to talk about, but I just wanted to bring this up only because I don't want you to think that I want you to know there's a reason why we teach you what we teach you. And I want you to be cautious going forward, just because I want you to be safe. I want you to be good with practice. You know what I mean? Okay, so today we are going to talk about our endocrine system. So there is a 10 PowerPoint thyroid that is just a review. And by review, I mean literally this is a thyroid, this is high, this is low. Here's your life-threatening high, here's your life-threatening low. That's it. Okay, because did you have thyroid previously? Is that something you're familiar with? Okay, so because this is complex, I just was gonna hit the high and low in the treatment, right? That's it. So I can record a little micro lecture and post that as well. It's under the lab section. Okay, just because we're tying in endocrine, and I know that Kaplan will focus on that as well. So we're gonna start with the pituitary. So if you're reading these along, there's gonna be multiple times where it's gonna say, see adrenal lecture. And the adrenal will say, see pituitary lecture, because the system functions together. But we're gonna start with the pituitary gland, which is kind of called the master gland because it's responsible for most body functions. It has some play in that, and it's regulated by the hypothalamus. Okay, and we know there's multiple things that could mess this up. So there could be something wrong with the pituitary or the hypothalamus. It could be a trauma. You could have some type of a tumor or some type of a blood supply issue. So something happens that causes the pituitary to not function correctly. And if you look at where it is, it looks kind of like the little uvula, the hanging ball in the back of your mouth. It's deep in the inside of the brain. Actually, if you could put your finger straight through your nose and go in, you would actually hit it, okay? So it has an anterior side and a posterior side. So it's kind of like two little lobes put together, okay? So the posterior side regulates anti-diuretic hormone, right? And so there's a lot of word soup in this. So I suggest you making a list of what all the abbreviations are so that you know what your different hormones are, because it'll make it easier for you. So we're going to call it ADH. We also call it vasopressin. But what that does is that makes sure that we absorb water in the kidneys. So we do not diurese, so anti-diuretic, so it holds the fluid in. The other thing that it produces is oxytocin, and you're going to talk about that more in 2030, because that has to do with the muscle contraction of the uterus. We talk about it with lactation, okay? But when we're looking at our ADH, so our anti-diuretic hormone, I don't want you to get confused by the arrows, but it's the easiest way for me to visualize it. So it makes sense. If you do not have enough anti-diuretic hormone, you're going to get rid of a lot of water, right? Because your body does not suck it back up. If you have too much, it's going to suck up too much water and you're not going to have the good urine output that you need. So just understanding what happens if you have too much or not enough. Okay, the arrows go the opposite way. So here's our first syndrome, our first disease process that has to do with the pituitary. And this is your syndrome of inappropriate ADH, okay? This means there's too much of it. So if there's too much antidiuretic, that means that we are gonna have tons of excess water that we don't get rid of. Now, with this, it is in our vascular system. It's not gonna be third space. So you're not gonna see edema everywhere. You're not gonna see tons of swelling. It's in the circulation, right? So what that's gonna do is it's gonna completely mess with our electrolytes, especially our sodium. It's gonna water everything down. Okay? So just remember, you're not gonna have much urine because it's not excreting. So you're gonna have labs that are really messed up and very, very diluted. But your urine is gonna be very concentrated, okay? So even though you have too much fluid, you can't get rid of it. So the symptoms you're gonna see have to do with mostly the diluted sodium. So you're gonna have your mental status changes, you're at risk for seizures, or swelling in the brain. You're also gonna have a lot of low sodium as far as muscle cramps, nausea, vomiting, diarrhea. And the urine is gonna be very, very dark, very concentrated. From a vitals point of view, if you have all that extra fluid, it's very similar to what you'd see in congestive heart failure. You're gonna have a high heart rate, very bounding pulses. You might have some JVD where the vessels are swollen in the neck, all because we just have so much water. Okay, so the reasons why could be a tumor. It could be, again, a trauma or an injury, a stroke. Or it could be a side effect of some medications. So different things that could be causing your syndrome of inappropriate diabetic hormone. So what we need to do is we need to treat your sodium. So we're gonna give you salt and we're gonna cut way back on your water. So it's not uncommon to have 500 mLs of fluid restriction a day. They're that water intoxicated. So we need to be very careful of how much fluid we're doing. So every IV flush, we're gonna only do, 2 or 3 mLs instead of the whole 10 mL syringe, right? If we flush the G tube, we're not gonna do extra water. We're gonna use saline. So we've got that isotonic. So we're introducing the salt. Okay, very much have to watch the seizure precautions because as the sodium drops, we're at risk for seizures. Okay. We can start doing some medications. We can try some loop diuretics to get rid of the fluid. We can try different antibiotics to suppress the ADH formation. We can give a medication, the tolvaptan, a vasopressin antagonist, basically reverses it. Or here's another thing we can do, but we want to be very careful, a 3% saline. So that's a lot of added salt, but we have to be very careful with that because just like not enough salt is bad for the brain, too much salt too quickly could cause brain damage as well. So we can do the hypertonic saline, but be really careful with it. Really, really do a lot of observation. Okay, so here's just your basic. We can reverse the ADH. We can give you extra salt, we can get rid of the extra fluid, but we have to make sure we are monitoring what's going on every 2 to 4 hours. Because as we're changing those electrolytes and fluids, we can have some change in condition. Okay, does that make sense? Second condition that we're going to talk about with pituitary is the flip side. So this is not enough antidiuretic. So this is letting all the water. So diabetes insipidus is called water through a sieve. It's just water coming in and pouring right back out. So we have tons of excess urine and we have, it's very, very dilute. Okay, so because we're getting rid of so much water, now we have too much salt because the water's not staying in long enough to take the salt with it. So now we have a super dehydrated person. Okay, so they're gonna be thirsty. They're gonna have the polyuria and the polydipsia part. They're gonna look like they're diabetic, but they're not. This has nothing to do with actual diabetes. It's just because as fast as they're drinking, they're peeing it right back out. Okay, so they're gonna be extremely dehydrated. Okay, so think dehydration and everything that comes with it. They're gonna have muscle weakness. They're gonna have pretty much the presence of shock, right? When you're that dehydrated. So they're gonna have low blood pressure and high heart rate. They're gonna have weak pulses. And if we look at our lab work, the urine is gonna be like water. It will literally look like you took warm water out of the tap and put it in a cup. But if you do your lab work, your values are gonna be sky high because they're so dehydrated. So one is very, very overhydrated, one is very dehydrated, okay? This can be something that they have to live with depending on what's causing it. If it is all of a sudden thing, or if it's something that is gonna happen continually, we just have to make sure we treat it. So the other one was more, it could be trauma, it could be a side effect of a med. This can be a genetic thing as well. Okay, so how do we know if they have diabetes and they're super thirsty and peeing a lot, or how do we know whether it is diabetes insipidus, which is not diabetes, it just looks very similar. So what they do is they withhold fluids. So they purposely try to dehydrate you even more. And then they give you antidiuretic hormone. Okay, so if you are super dehydrated and you're still pouring out urine that isn't concentrated, then we know that that's the problem. Because even making sure you're even more dehydrated, you're still not able to concentrate the urine, and that's what tells us. So what we have to do now is we have to get rid of salt. Okay, we need to really make sure we're watching our labs. And safety, these people are gonna be peeing literally every 5-10 minutes constantly. So whatever we need to do to ensure as they get more and more weak, as they get more and more dehydrated, they may have some safety risks. So please make sure we're looking at that. We can give them some desmopressin, which is an extra ADH. We can give them more vasopressin through the IV. We can give them hypotonic, right? And that is it pulls the sodium out, not pushes it in, pulls it out. But our whole goal is to just deal with that low volume. We have to fix it. So if you look in your book, they kind of compare the two. And this is a really nice video. It's not animation, it's a lady kind of explaining it. But here's what you need to take away from these two things. Understand what comes out of the pituitary and understand what it looks like. Which one has lab values that are high? Which one has lab values that are low? This would be a great opportunity to make a Venn diagram or a chart or something to kind of understand the two. Endocrine is a very popular NCLEX question because it's so complex. So if you can understand it, then they know, okay, critical thinking is good, and they will like move you right along with the rest of your 70 questions. Okay, that's your posterior pituitary, what we just covered. The anterior then has to do with basically all things hormone. Okay, all of these hormones are regulated by the front part of the pituitary. Okay, and I'm not asking you to memorize what each and every single one of these things do, but we'll talk about the thyroid stimulating in that little mini thyroid micro lecture. And we're going to talk about the adrenocorticotropic. There's a lot to say, so we're going to call it ACTH. We're going to talk about this in the adrenal. Okay, the rest of them have to do with growth, puberty, development, sexual function. Okay, so most of the time, if your anterior pituitary is misfiring, it's because there's a tumor. There's a tumor on it, a tumor on the pituitary that's making everything secrete more. Right? That is usually the problem. And we usually only find that when either we have some type of issue with our growth or we start to have problems right here. Because remember, it's like directly in the middle of your brain, straight this way. So when you start having vision changes or you start having like head pressure, that's usually how we find it. If for some reason we don't have enough of our hormones, The tumor can sometimes impede it, but usually it has to do with something that has happened outside of your body. You've had radiation, you've had surgery, you've had some type of a, stroke to your pituitary gland, something like that. Okay, so this is just a quick review of what the hormones are. FSH, again, that's a follicle stimulating hormone. It has effects on both female and male. Luteinizing hormone, again, female and male, and this has to do a lot with sexual function. Prolactin as well. It has effects on male and female. And then the thyroid stimulating hormone is what's responsible for making sure that you have T3 and T4 in your body, right? Which is the actual workhorses of the thyroid that actually make things happen. Okay. Your ACTH, see adrenal lecture, right? These are going to tie together. So this is the hormone that has to do with your cortisol, right? So this is your response to stimuli. This is your response to fight or flight and all these other things. So your ACTH, just kind of circle that one, and we're going to talk about that in the next PowerPoint, okay? This is the one I want to really focus on your anterior pituitary is your growth hormone, okay? So this is what causes us to use those proteins and amino acids to actually develop and to let our muscles grow so that we are able to develop. So it also makes sure we have plenty of energy to grow, and it makes sure that our bones and our cartilage are able to expand. So growth hormone is super important. So what happens when we have too much? Okay, so in children, highlight circle, in children, gigantism happens, and it has to be kids because it has to be before those epiphyseal plates close. So if I have too much growth hormone before I turn whatever puberty is, right? 12, 13, 16, 18, then I can end up being gigantism. These are the people you see on the Barnum and Bailey circus of people that, you would go and see, like the geeks and freaks. These are people that are very, very tall. We're talking 7, 8 feet tall. Andre the Giant, really tall, with lots of cardiac issues because of it, because everything is so big. But they're going to be proportional. They're just going to be incredibly tall. We do not see this very often anymore because we have such good detection, right? So we know if a child is growing way too quickly, we can find this. They may still be tall, but we're not going to end up with 8 feet tall very often, right? Occasionally in other countries, you're going to still see it, like the Chinese basketball players who are, 8'2" or whatever it is. Okay, but we usually can find the cause of it, which is the tumor, and we can usually get it taken care of. In adults, we still have too much growth hormone, but it looks very differently. This is after our normal growth plates have closed, so we're not going to get any taller, okay? But we are still going to keep growing. But what is going to grow are body parts like our forehead, our hands, our feet. So people will start to say things like their hats don't fit anymore. They have to have their rings resized. Their teeth aren't lining up anymore because their jaw is growing, right? Maybe they have some enlargement of some organs, but this is really slowly happening. And so they don't always recognize it because you're not getting taller, but things are just starting to change. What we will see most often, again, are the increase in your head, your feet, your jaw, but your facial features will also start to change. Again, if you think of Andre the Giant, I don't know if people even know who that is anymore, but very wide nose, thick lips, okay? So this is what this lady looked like before, and here is what she looks like now. Same with this gentleman here, the wide nose, very thick lips, prominent jaw, okay? So when we talk about coarse features, that's what we're looking at. What we're more concerned about is your head, right? So if this is all going on, it is going to mess with your intracranial pressure, okay? Because your skull acts as like a brain helmet, right? So they may present with a severe headache. Increased intracranial pressure Okay, I really want you to recognize what those signs are because they're very important. Change in level of consciousness, seizures, low blood, high blood pressure, low heart rate. What we call is sunsetting or papillary edema, right? All these different signs that are showing us that something's going on with our brain. If your jaw isn't lining up, it might impact your eating, but if your brain is being affected, it's more of an issue. Okay, they may also have issues with vision, again, everything right in here. Okay. These are some pictures of gigantism. Again, you can tell these are older pictures, but that's just kind of a regular size person versus the extraordinary growth because he was growing before his plates closed. Okay. This is a video of a lady who talks about the different signs that she noticed as far as her rings being resized, like I said, her jaw not lining up. And when she started doing some internet research, she realized like, oh, yeah, that's why my lips are thicker. So she actually kind of helped diagnose herself. So for gigantism and acromegaly, the way that we want to get rid of it is to go in and remove the tissue that's actually causing the extra secretion. Okay, so this going in through the nose, because again, that's right where it's at. Going in through the nose is the easiest way. You can try radiation as well, but there's always risks with that. So I'm going to show you this video. It's a little bit graphic, but it does a good job. Graphic, it wants me to say that I'm over 18.
This is a video of a transsphenoidal resection of a pituitary gland adenoma. The tumor is visible on this preoperative MRI. The surgeon inserts an endoscope in the right nostril and through the anatomical opening into the sphenoid sinus. The dural fold covering the gland is clearly visible in the sella tracheca. The surgeon makes a cross-shaped incision in the dura mater with a scalpel.
Make it look so easy. You just make an X, and out it pops.
It reaches into this incision with biopsy forceps and carefully pulls out the tumor in one piece.
There it is.
When all tumor tissue is removed from the cavity, the surgeon controls hemostasis. Artificial dura is cut to fit and placed inside the patient's own dura. Tissue fluids applied, and the sphenoid sinus is filled with hemostatic sponges.
So literally what that patch they put over it is the lining that surrounds your brain. Like that's all that is keeping you from having your cerebral spinal fluid leak out or anything else. They literally go up, pop a hole, pull it right out, and that is the same lining that covers all of your brain, which is a little terrifying if I think about that. Now, I show you this because that trans, let me see if I can spell it. So the endoscopic transnasal, so it's the transsphenoidal right? Oral, nasal, they can go through the nose or the mouth, transsphenoidal, endoscopic, removal, hypophyseectomy. So big, long words. But if you see those words, right? Transsphenoidal, hypophyseectomy, you're gonna picture that video of where they went in, pulled it out. So here's what we need to know though, is if they have that portion removed and we're that close to the skull, we're gonna have some major issues that we need to think about. So if we need to give medications to try to block the hormones as there too much of them are happening, we need to do that. But if they have had the surgery, which we know is usually the best choice, we need to watch out for what is coming out of their nose. Because of how close that is, we have that little fake dura. If they're blowing their nose frequently, we have to make sure that it's not actual mucus and it is not cerebrospinal fluid, okay? Because that's a bad day. So what we do is we take, when they blow their nose or they have leakage, we put it on a gauze and we let it dry. And if it is cerebrospinal fluid, you're gonna see a ring of glucose on that gauze or that Kleenex or whatever it is. And that's gonna let us know that it is actually fluid and not just snot and symptoms of having a nasal surgery. And we need to be aware of that. So just the key point of this is understanding where it is in relation to your brain. It will make sure that you do a lot of careful assessment. So other things we can do, we can give a dopamine agonist, we can give a somatostatin, we can give growth hormone receptor blocker, all of those to say we have to do something to keep it from happening. If we are concerned, we want to make sure we got it all. We do that CT or MRI. We can do a CT angiogram to see if we've got it all. And then we're going to do a growth hormone suppression test. Okay, so what we're going to do is we're going to give glucose and then we're going to see what happens. So if we have glucose in our system, it should help suppress some of that growth hormone. But if we give that glucose and it still is amping up and we have no change in it, then we know it's positive. So same as when we did the test for the diabetes insipidus, we're gonna go ahead and dehydrate them and then give them glucose and then see what happens. Okay, so you should be starting a list of like 3 or 4 different ADH, ACTH, those type of things. Then you should start a little list of tests. What am I gonna test for? Okay, what do I need to know about that test? The flip side is if there's not enough growth hormone, you have dwarfism. And we're not talking about a genetic, the chondroplasia, which is where they have a large head and a large torso, or I'm sorry, short torso, but regular size arms or legs. This is a proportional dwarfism that happens just from lack of growth. So a lot of times we see very proportional, they're just very small. And we do a pretty good job of watching kids when they're little to see where they fall on the growth curve. And if we do see them not growing, we go ahead and we intervene pretty quickly. So with the slow growth, they also may have a delay on the onset of puberty just because they're not maturing. Okay. So questions, we'll do some practice ones. See if you can flip back on your slides if you need to. So a client with a syndrome of inappropriate antidiuretic hormone, what would you expect to see? So SIDA-DH, are we talking too much water or not enough water? Too much water where? In this vasculature, yeah, absolutely. So what would we see with that? We would see A and we would see C. So we're going to see watered down sodium and we're going to see watered down osmolality. And it says osmolarity, but that's a typo. It should be osmolality. Okay. The specific gravity, that's pretty low. Polyuria, polydipsia, those are signs of the diabetes insipidus. Okay. All right, now we're going to switch. Diabetes insipidus. What do we know about that? Where is the water with diabetes insipidus? Out of the body. Yep, it just keeps pouring on out. So that top one says, I will drink up to 2 quarts of fluid a day. What do you think it is? B? Yeah. So with our patients that have diabetes insipidus, excessive thirst, we are not going to limit them on what they drink. If they want to drink up to 30 liters a day, we let them drink it because as soon as they're drinking it, it's coming right back out. We know that dehydration is the problem. Okay. Blood sugar has nothing to do with this. And usually they have weight loss because they're so dehydrated, right? They don't have fluids. Okay, acromegaly, is that adults or kids? Adults. Okay, so that transsphenoidal hypophysiectomy, we know what that is, right? That's the little thing in the brain. What do we watch for? So D, so we're gonna watch for glucose because we're gonna monitor that. Now, encourage them to brush their teeth. Why do we not want them to brush their teeth right after they have surgery? Everything is right in here, right? So if they get aggressive with brushing their teeth, they already have an artificial patch that's separating the top of their palate from their brain. We do not want them aggressively doing anything in their mouth. Okay, so we want to make sure they're not coughing. They don't want to do anything to increase the pressure or damage anything up in here until that heals because they're so close to their brain. Okay, does that make sense? Are we good on the pituitary? Okay, we'll take a break. We'll switch to adrenal and then we will do some our adrenal. Now, remember, these do kind of go together. So our adrenal glands sit on top of our kidney and they are divided into 2 sections, right? We have the cortex and we have the medulla. So the cortex is not actually the core, it's actually the outer portion. And that's where we get a lot of our steroid hormones, okay? The inner portion is where we get our catecholamines. So inner portion, the medulla, we think fight or flight. Okay, so if you would cut an adrenal gland in half, you can see we've got the capsule on the outside, and we've got that cortex lining, and then we have the inner section. The medulla is where, again, we do our fight or flight, and that's where everything comes from. So if you need to face danger, right? If you need to dial in for whatever reason, it is going to allow you to increase your blood pressure and your heart rate. Okay, they're going to send extra blood to your muscles and your lungs in case you need to run real fast if the bear is approaching. It's also going to deviate. We're not worried about digesting food right now. And we're going to make sure that we have enough glucose. Again, if that bear is approaching, I want lots of blood in my muscles. I want my lungs full of air. I want plenty of energy ready to go so I can sprint. Okay, that's what the adrenal medulla covers. The cortex itself then is what we need to maintain life, right? And I know that sounds like a really broad topic to maintain homeostasis, but really it is. In order to maintain our synthesis, our metabolism, all of our hormones, it all comes from this area, okay? So the 2 things that we focus on are aldosterone, and that's what tells our kidneys to pull in the water, get rid of the salt, whatever the balance needs to be. Let's get rid of potassium. That seems too high. So that's very important. And then it also does our glucocorticoids, which have to do with our immune system, has to do with our breakdown of our fats and our proteins. And this is where we end up with a problem. And we're going to talk about these in a minute. If this glucocorticoid section is not functioning correctly, that's where we get our Cushing's and our Addison's, right? So those are the 2 that we're going to focus on here in a minute. The other thing that the cortex does is our androgens, right? So this allows us to have a sex drive. It allows us to have our secondary sex characteristics like our maturing and our muscles and our hair development, those type of things. So we're gonna break it down into, there's actually 3 things we're gonna talk about. What happens with the cortex if we have not enough or too much? And then we're gonna talk about the medulla if you have too much. So there are really only 3 main disease processes that we need to know. We had 2 for pituitary that had to do with our diabetes insipidus and our SIDH. And then we had 2 with the growth, right? Our gigantism and our acromegaly. Here, we're gonna break it down, we have 3. The first one we're gonna talk about is our Cushing's. This is our hyper. So we can talk about Cushing syndrome or Cushing disease. They all fall under the same umbrella of Cushing's. And basically there is too much cortisol in your body. And what happens if you have too much cortisol in your body? Okay. Most of the time, this goes back to that pituitary, right? That ACTH. And if that is stimulated too much, the ACTH is going to tell the body to keep cranking out more cortisol. Okay, so we know that it can also happen if you are on something to suppress your immune system. So our people who are on our anti-rejection meds for their transplants, or the people that are on the methotrexate for their rheumatoid arthritis, those type of things. So in your book, it has a really not flattering picture of a person. And that's what I want you to think of with the Cushing's, right? These people will have a very large trunk and very small legs. They're gonna have lots and lots of stretch marks. Okay, they're gonna have lots and lots of purple stretch marks because their skin does not have elasticity. They don't have collagen. You're gonna have very weak bones and you're gonna see them kind of stooped over. Okay. And because their immune system has been overly stimulated, it stops working. So they're gonna have a poor immune function. I am not a big fan of mnemonics, but this one I do like. It seems to make sense. Okay, so big, thick trunk, moon-shaped face, lots of stretch marks. Okay, lots of male characteristics in women. We call that hirsutism. And here's another one. We call it a buffalo hump. But if you ever see people that are very obese, and again, like 600-pound life, it's a very weird distribution of weight. So they often have like that big apron here, and they often have that big dorsal-cervical fat pad here. And that all comes with the Cushing's. Okay, it's a very unique appearance to it. From looking at them, right, we're gonna look at some diagnostics. So we expect there to be elevated ACTH levels because that's what tells your body to crank out the more cortisol. We expect there to have some salivary levels, right? So you can do a quick swab. From an electrolyte standpoint, we're gonna see high glucose, high sodium, low potassium, low calcium. Okay, and again, that makes sense. They're gonna have weak bones. They're gonna have difficulty with electrolytes. And we're gonna see plenty of cortisol in everything. Okay, even without stress, right? Because that's what our body responds to, even without that. So we're gonna do another test. And this is where we give you a dexamethasone. So we're gonna give you a steroid and we're gonna see what happens. Normally, after I give you a steroid, it should suppress your cortisol levels. In this, it doesn't. So if we are trying purposely to get you to make less cortisol and you still can't, that tells us that you do have Cushing's. Okay, so here's 3 different medications you can take. You can take something to decrease the stimulating hormone, the ACTH. You can take something to keep it from working, right? And this is actually a medication we often use for antifungal, right? So multi-use. Or we have something that affects the adrenal gland itself. Okay, so there's 3 different routes that we can take. We can also go in and just cut out part of that adrenal gland. Okay, So if we need to do that, we do have to remember that since that's that gland that controls our metabolism and maintains our homeostasis, we do have to have replacement for life. So if something happens to your adrenal glands, you do have to supplement. It's like a type 1 diabetic. You have to have you have to restore it. Okay, if it's the pituitary problem, we can go in and do what we just saw, up through the nose, pull out the pituitary tumor that's causing too much of that ACTH, or we can try to eradicate it externally. Okay, so I had these in all different colors, and the feedback was is that a lot of people don't like a lot of colors. So I just picked 3 that I thought were important. So for our patients, because they have a weakened immune system, they're at risk for infection. Because they have so many messed up electrolytes, gotta make sure they have good nutrition. And then especially because of the high potassium, we have to watch them for cardiovascular things. They're at risk of dysrhythmia. Okay, these things not necessarily are not important, I just didn't color them. Right, so again, poor bone density, their risk of fractures, make sure we monitor their fluid. And because there are so many physical changes that happen with Cushing's, there is some self-esteem issues, right? Because of the weight distribution, because of the stretch marks, the moon face, the fat pad, we do need to take it into consideration. Okay, so here's all the different things we can do to tell our patients. Especially if they had a adrenalectomy, they need to make sure they wear a medical alert bracelet so that we know that they are at risk of these different things. Okay, this is a video if you want to listen to a lady describe all the different symptoms that she had, starting with this fatigue and this brain fog, and how she got diagnosed with Cushing's. So if you have somebody with Cushing's, what is your priority going to be out of those 4 things? And the answer is A, because of the fluid shift, we've got to make sure that they're monitoring their weights. If they go up dramatically, we've got to figure out what's happening, right? Is there a sodium problem? Is it a fluid retention problem? Okay. And looking at labs, okay, what would we expect? This is a SATA practice. So all of them except D. Okay, so all of these are slightly off. Okay, except for your lymphocyte count. So we would expect your sodium, potassium, calcium, and glucose to all be off balance with Cushing's. Okay. We good on Cushing's. Okay, here's our flip side. If we don't have enough cortisol, we develop Addison's. And probably the most famous person with Addison's was probably President Kennedy. He had that very, very bronze colored skin that we now know comes from Addison's. Okay, most people fall into this category where they're chronically adrenal insufficient. If it ends up being an acute problem, then we have a medical emergency. So Addisonian crisis is very different. Most people live in this chronic area where they've got not enough cortisol, but it can happen suddenly, in which case we have a big problem. So most of the time, there's an autoimmune problem that destroys the adrenal gland, and that's why you don't have enough secretion. Okay. Everywhere else in the world, that usually happens from TB. Here, autoimmune, and then external factors. If they have an acute crisis, most of the time that's caused by they quit taking their medication. So they're on supplements, and for whatever reason, they stop taking it, and that can cause it to happen. Okay, so more arrows, but think about it. So If you don't have enough aldosterone, right? You are not conserving sodium. So you're gonna end up with low sodium, because it's gonna be too excreted, and high potassium. And that's also gonna get rid of your glucose, as it's getting rid of all your extra fluids. Okay, so this is sort of similar to our diabetes insipidus, which is we're not conserving what we need to conserve, and that leads to our dehydration. Okay, the big difference right here is that they have a big craving for salt. Their body knows that they're excreting too much, and so they will crave potato chips and super, super salty things to try to replace it. The other kind of hallmark is that bronze skin, okay? That kind of darker pigmentation, the older they get, the more pronounced it is. And that's the bronzing that is, we sort of think of as the trademark of our Addisons. The other thing, anytime you have any disease process that has high potassium, you can just go ahead and know that cardiac dysrhythmia is gonna be a problem. Right? Because the heart is very susceptible to that. This is a really interesting video, if you have time. It's a young guy, he's like in his late 20s, and he had been misdiagnosed with multiple things before he got diagnosed with Addison's. And so the thing that actually tipped it off was he lived in California for a while and he moved back. And when he moved back, he never lost his tan. And his tan kept getting a little bit worse and a little bit worse. And people kept saying, oh man, your tan is so great. And he's like, I haven't been in the sun in a long time. And that's how they kind of just figured out he had Addison's. But at the 22-minute mark, he talks about how he maintains it. So he talks about the pill that he takes a couple times a day, a couple dietary things that he changes, and he's able to live a very full life. So kind of an interesting video from a younger person, which I think is sometimes nice. If you have Addisonian crisis, again, this is you are fine, and then all of a sudden this is not a chronic, okay? We are gonna have these symptoms develop very, very quickly. It's gonna start with a high fever, horrible pain in the abdominal, low back. You're gonna be vomiting, diarrhea. It will progress to shock and coma. So if you have any of these symptoms, maybe they have a history of Addison's disease, maybe they have long-term steroid therapy and they quit, your treatments are going to be replace the volume and administer glucosteroids as fast as you can get them ordered. Okay, and that's going to avert this crisis. Okay. Again, what are we going to look at for our Addison's? We're going to have high potassium, we're going to have low sodium, low cortisol. Okay, here's another test. What they're going to do is they're going to infuse ACTH, which normally should crank up your cortisol. And when they do that, nothing's going to happen. Okay. So if for some reason it's a pituitary issue, that'll tell us that as well. But most of the time we're using that ACTH test to find out if they have primary adrenal insufficiency. So if we diagnose it, they're going to take some type of cortisol or corticosteroid the rest of their life. And that's going to balance everything out and they will do very well. They're, other than the bronzing of the skin, they really should not be the dramatic body symptoms and the body changes that we see in the Cushing's. So again, high potassium, I'm going to hit on this again. Make sure you're watching their fluids and their electrolytes. Again, we're going to watch their salt and we're going to watch their fluids because they do get very dehydrated. With that, we need to make sure these are the two most important things here. They have to take their medication every single day. They cannot miss a dose because if they do miss a dose, they're at risk for their Addisonian crisis. And they have to understand that this is not temporary. This is lifelong. So once we find out that you're not making that cortisol, we have to keep supplementing it or you will go back to where you were before. Okay, all the other stuff we know you can make sense, but those are the two things that we have to stress and this isn't temporary. Okay, this is an anomaly all on its own. This is called a pheochromocytoma. Has anyone ever heard of a pheo attack? Okay, it's pretty rare. This was actually on an episode of Chicago Med last season, which I thought was really funny because I had never seen it on TV before. What happens is you have a tumor in your adrenal gland that does not know when you are in fight or flight mode, so it just randomly throws you into it all the time without warning. So on the show on Chicago Med, this girl got diagnosed with panic attacks. And of course, the one doctor who saves the world figured out that it was this random tumor that was just spitting out norepinephrine and epinephrine. And then these were the symptoms she was having. So all of a sudden, your blood pressure is going to go up. You're going to end up with all that vasoconstriction, all the things that you need for fight or flight. Blood to the muscles, lungs all full of things, glucose spiking because you're ready to run, but nothing's happening because it all just comes from a tumor. So just understand that the blood pressure will go very, very high because you're not needing it. And if it goes unchecked, it can be life-threatening. So pheochromocytoma is the tumor, but we call them pheo attacks because they don't happen all the time. It's just whenever that tumor decides to spit it out. So the treatment for that is you have to go in and take the tumor out. If you have to take out the whole adrenal gland, then you need to have replacements. This is a video of what happens during a pheo attack. Okay, so check your knowledge. Addison's disease, is this too much or not enough cortisol? Not enough. Okay, so if we are teaching them, what do we have to teach them? Yeah, B, C, and D. So doesn't matter when you take your meds. You're low salt anyway, right? So go ahead and eat those chips, that's fine. But B, C, and D. They're more prone to infection. Let us know if you get sick and please don't stop. Okay, and then what should we expect? So everything but E, right? So we know that they go high glucose when we have our Cushing's people. It's usually on the lower side for Addison's, but everything else we expect. We expect low salt, high potassium, high calcium, and some kidney issues because we're going to be dehydrated. Okay, so if we have acute adrenal insufficiency or adrenal crisis, what do we do? So we are going to expect B, C, D, and E, right? So we are not going to do the hypotonic saline, but we're going to do all the other things to try to get the potassium back in the cell. So remember, if we have high potassium, we use our insulin, we use our glucose. And what's the third thing that we use when we're given our potassium? Or yeah, triad. Remember? We have calcium. So we give all those together. That's it. That is all I have.